Hey, what's up everybody? My name is Brandon Hunter. I'm a board certified pediatrician and pediatric ICU doctor. And again, today we're talking about RSV. This time we're focusing on bronchiolitis and respiratory distress. So to start out, for me, respiratory distress has two big things to look out for. How fast is the baby breathing, and then how hard is the baby breathing? Remember in the last video, we said in bronchiolitis, all the little airways are inflamed with virus and debris and kind of occluded. So it's harder to get the amount of air in and out that you would want to. So we all have a muscle called the diaphragm underneath our lungs. And when we're at rest and healthy, this does most of the job of breathing. And so air goes in and out and no big deal. But there's a bunch of other muscles we have that can help to open up the chest and that can help to get air in if we need them to engage. And these are muscles in the neck, in the chest, in between the ribs, and in the belly. And these are called accessory muscles because they're usually not needed. They're just kind of like an accessory to the diaphragm. But when a baby has bronchiolitis, they may need to engage those to get air in and out. And so this is where we see distress or hard breathing. But let's say even with all that effort, a baby's not able to get the size breath that they want, well, then they can compensate by breathing faster. And remember that babies at baseline breathe pretty fast. So adults breathe 12 to 20 times a minute. Newborns, when they're born, breathe 20 to 60 times a minute, and that's normal. But relative to baseline, so relative to how they are when they're healthy, they'll breathe even faster when they have bronchiolitis and are distressed. So what I'd say jumps out to me in this video is subcostal retractions, or underneath the rib retractions. And these are kind of between the chest and the belly, and you can just see this shadowing, a little horizontal shadowing every time a breath is taken. But I also note that there's intercostal retractions, or retractions that are in between the ribs, because every time a breath happens, you can kind of see the ribs flare out, like they suddenly appear where you wouldn't normally see them. And so those are both signs of distress. The next thing I see is called head bobbing, where every time a breath comes in, the baby's head kind of goes up and down. Now this is because the neck muscles are firing and flexing, again, to try to open up the chest and get as much air in as possible. And it's not perfectly visible here, but you can also see a little bit of what's called nasal flaring. And in this case, the nostrils sort of flare open every time a breath is taken in. And this is a defense mechanism where the baby's trying to increase the surface area of those nostrils to allow more air to flow in, and again, is a sign of respiratory distress. And then in this video, the audio is critical, and so I hope it comes through. But we're seeing some of the similar things we saw before with the subcostal retractions just above the belly and under the chest, the intercostal retractions every time a breath comes in, the head bobbing, you can see it move every time there's a breath. And then finally, there's this sound. So that sound is what's called grunting. I don't have time to talk about why grunting happens here, but had I just heard that audio and not seen the video, I may just say, oh, it just sounds like a baby who's fussy or whining. But when it's combined with respiratory distress and you hear it kind of at the end of every breath, just like that, it's actually called grunting, where the baby's trying to keep their lungs open and prevent collapse.